Hello everyone, my name is Herb Corley, paramedic down at Whitney. This is February's monthly education. Joining me today is Dr. Simonson, our medical director, who will be covering a primary topic of toxicology.
Good morning, guys. Putting this together, what I tried to do was pick agents, drugs that may apply to us in the field, whether we know it or not, as opposed to just looking in a tox book or calling the Poison Control Center and saying, I've got this and this and this. Then toxicology can be very, very boring. So there's 4 or 5 things that we need to know about tox right up front before we get into specific agents. The way we approach the poison patient, for lack of a better term, is called toxidromes. And it looks at various things. And through the course of the lecture, I'm going to give you some of those toxidromes and have you memorize, for lack of a better term, this drug fits in this toxidrome, etc. But there's things in toxicology you have to understand that toxicologists live and die for. One is called the LD50. LD50 is the lethal dose of a drug, an agent, whatever, that kills 50%. The other one is protein binding. Protein binding keeps you off of dialysis. That's why, for instance, when we get into Tylenol and aspirin, we're going to talk about drugs which are highly protein bound, by default probably aren't dialysable. By that I mean literally dialysis. And then we're going to talk about acronyms, things that stick in your head and you go, I think this has some application. So the first one I want to talk about is a case that I saw when I first started. Got a call from Dallas Fire Rescue. We're bringing you a guy who was spraying the roses, and now he is extremely bradycardic. He's got diarrhea. He's salivating all over the place. We'll be there in 10. 10 minutes pass, 12 minutes pass, the box pulls up, and nobody gets out. And one of the nurses goes out, and one of the Dallas medics is sitting on a bedpan doing you-know-what. And come to find out, this guy was organophosphate. If you take the blood pressure or touch the patient without any gloves, it's rapidly absorbed. So we now have 2 patients from spraying rose bushes. And that's called organophosphates. And the mnemonic is sludge: salivation, lacrimation, urination, defecation. You got to steer clear of these people. Don't touch them. The treatment is very interesting. The treatment is atropine in humongous doses. That's where you get a hold of the pharmacist and say, how much do we have in the building? And you start with atropine, and then we break it up into muscarinic and nicotinic, what effects. And these people are pretty profoundly diaphoretic. They got a pulse of 20. They've got terrible diarrhea. They're altered mental status, and you don't want to become a patient with organophosphates. Bear in mind that in 2000 and 2005, the FDA no longer allowed organophosphates as something that you can get like Durspan at your nursery to spray plants and everything for this exact reason. So this is a springtime drug. This is what you see when you arrive somewhere and somebody doesn't fit. I don't know what it is. He ain't right. Always think organophosphates. Let's talk about another thing that I found interesting is since I work in 2 teaching hospitals, this is the flu season. Guess what the flu looks like? Aspirin toxicity, the exact same thing. Febrile, muscle aches, joint pain, not themselves. So if you don't think about it, you're going to miss that during the flu season. It also looks like aspirin and vice versa. Let's look at another one, and that is carbon monoxide poisoning. Can't smell it, can't see it, especially this time of the year in people who either haven't turned their heater on or have a different idea about what a heater is. You can bring the barbecue grill into the garage and crank it up, and the next thing you know, everybody looks like they have the flu, and then they die. Carbon monoxide is tasteless, odorless. It is an indolent toxin, especially in EMS, that we can get in trouble with. So bear in mind when I ask a patient who's hypothermic, do you have a heater? And then I go back and I say, is your heater a Weber barbecue grill, or is it coming from legitimate sources? Because carbon monoxide looks just like these. While we're talking about that, we need to touch base with the role of hyperbaric for carbon monoxide poisoning. If you want to know the truth, the data that comes out of most tox registries involving carbon monoxide are EMS personnel. And one of the things that they started to look at years ago was you survive the event. You put a non-rebreather on them that decreases the carbon monoxide level. Within 45 minutes, everything looks good. But the wife says, we took him home, and for the past 4 or 5 years, he ain't right. He's just not on his game. So it's called neurologic sequelae of carbon monoxide poisoning. And the data that we get out of that is primarily from people in our line of work. So bear in mind that you may survive the event with carbon monoxide. Whether you believe in hyperbaric or not is irrelevant, but long-term sequelae. And it wasn't until they started to question people who were leaving their job early, retiring early, and there was a significant band of these people who were actually carbon monoxide poisoned. All right, here's some ones that if you've been around long enough, you'll remember sarin gas, the Toyota sarin gas. Sarin and ricin are 2 drugs which are used for mass execution of people. In the Tokyo sarin gas, the majority of the people actually drove themselves to the ED, so the cohort of how many did they actually see, we don't know. It also is an odorless, smellless gas, but its long-term effects are extremely long, and they die of respiratory arrest. These people have to be intubated almost immediately. Interestingly enough, it comes from castor beans, and the majority of it comes from nations that make brake fluid, which is where castor beans get involved. So think of sarin and ricin. Page 2. All right. Going back to our organophosphates, the problem is cholinesterase. You may treat them with atropine and their rate picks up and their diarrhea stops and everything, but they continue to have muscle mass, involuntary movements, and the drug of choice is pralidoxine for those. If you don't give it, then you've only taken care of half of your problem, which is the hemodynamic issue with these. And this too is a drug that most hospitals have, albeit on a limited supply, because you can imagine this isn't that common an adulterant that we get into. How could we talk about anything in EMS without talking about alcohol? I think alcohol is probably the reason most of us have a job in some form or fashion. The alcohol we traditionally think of is, alcohol. There are some alcohol cogeners which you need to be aware of. Everybody's been to a buffet where there's a little thing underneath warming up the whatever food products, and in there is methanol. And methanol is an extremely toxic alcohol that can cause long-term sequelae. And how many of you have ever had a water leak in your car and you go in and somebody takes a woods lamp out and go, oh my gosh, what's this blue stuff here? That's ethylene glycol. And the fluorescein that's in there is in there for a reason. You can detect leaks with a woods lamp. Who'd have thought that it also is an alcohol-based system that can cause problems? No matter what alcohol we're talking about, the savior is alcohol dehydrogenase, ADH. When I was a resident, if we couldn't get fomepizole to reverse these, then we would send one of the interns or somebody to the liquor store who had gotten into methanol or isopropyl alcohol back then and bring back a couple of bottles of cheap whiskey. What it did is alcohol in that sense increased the alcohol dehydrogenase and separated it from the enzyme. So you actually could give somebody a bottle of Jack Daniels and say, we can't afford fomepizole here at the University Hospital, but just keep drinking. The guy will be back tomorrow going, this is a great gig you got here. I'll be back tomorrow and see you. So when we talk about alcohols, you have to talk about anion gaps. Now, like everything else we do, we're shooting from the hip based on clinical acumen. How many people are doing istats in the field? I have no idea. How many people are doing lactates in the field? I have no idea. But for the most part, we lack the ability to CT scan. We can't get a chest x-ray. We can't do this. We can't do that. The best case scenario would be looking for somebody with an anion gap. And everybody knows the mnemonic for that. Methanoluremia, DKA, paraldite, idiopathic isoniazide, and lactic acidosis. And you can have another one, metformin. And how many people do we see who are diabetic who are on metformin? So once you get your sodium, potassium, and your chloride and everything in your chemical form, in the equation you can find out, wow, this guy's got an anion gap. What is it? That's the traditional thing we talk about, DKA. Well, their CO2 is 7 and their gap is 23, and you're going, that's a big gap. Alcohols do the exact same thing. The problem is a lot of these don't have an odor to them. If you'll know, recently people have talked about isopropanol in the nose to stop vomiting. And because we were beyond Haldol, we had already used Zofran, we used Compazine, Tygan, and then people went to isopropanol in the nose and they would stop vomiting. There's a cohort of patients that we were able to discover who actually developed an anion gap metabolic acidosis from putting a simple piece of alcohol in your nose where you would stop vomiting, and these people ended up with an anion gap. Okay, let's go down to, everybody heard of fomepizole. If I'd have been smart, I would have invested in this years ago and I wouldn't be giving a lecture while it's raining outside. Fomepizole is a drug which reverses and incites alcohol dehydrogenase. Readily available. Its uses for all of these. If you're wrong, no foul. You don't increase anything as far as their kidney dysfunction or anything else. So fomepizole is very common with this. Also, you want to know that with the mud piles, if you and I have a beer and you got an intact liver and your alcohol comes back 150, and you're going, okay, if I metabolize it at 25 to 50 milligrams percent per hour, I should have zero alcohol in 4 hours, so I should be awake and alert. If I drink for a living and I got liver disease, then that goes down to 15 milligrams percent per hour. So at 4 hours, and you're going, I can't get a second alcohol, but he still is intoxicated. So it's a predictor of your alcohol is 100, you got an intact liver, in 4 hours you should be able to say your ABCs. And if it's not, then go looking for another substance that causes that. All right. Does everybody know what the side effect of methanol is, which is very, very, very bad? Blind. These people have irreversible retinal damage, and they actually can become blind if you miss it. And that's where you're going to pick it up on your anion gap and where you're going to pick it up on your serum osmoles. Again, two entities that we don't have access to in the field. All right, let's talk about one that I think is one of my favorites, and that's Anticholinergic syndrome. We break the nervous system up into parasympathetic and sympathetic. This is one that is entirely driven, much like organophosphates, by physical exam findings. And what it does is it blocks acetylcholine. And I always have to read these off because I've looked at them so many times in my career. Mad as a hatter, dry as a bone, blind as a bat, red as a beet, full as a flask. So when you think about who gets into this, you go to a nursing home. Guy's got a fever. He's red. He's got urinary retention. Oh yeah, by the way, he took Benadryl, and I think he took some Sudafed, and these people develop anticholinergic syndrome, and unbeknownst to them. So this is a drug where you really want to know, or an entity where you want to know what drugs is he on. What happens with these, where they, for instance, how do you get so hot? It blocks the ability for you to sweat. So you go in and you're thinking, man, this guy, he's got a bladder full of urine, he's beet red, he can't sweat. What is this? This is anticholinergic. Very, very interesting because it's all, we complain right now about, you have the drug list. Can you tell me exactly what drugs they're on? And the nursing home population is very infamous for doing this with anti-Parkinsonian drugs. And you look at it and you're like, this drug causes an anticholinergic. It is reversible if you catch on to it. Otherwise, you got all kinds of problems with core temps of 104, 105. They're extremely red and you're chasing down, is this guy septic? Oh, he's got urinary retention, and does he have a problem going on there? So anticholinergic, you go to the drug list and you're going, I want to see what this guy's on. All right, and what are we going to do for this guy? Atropine takes care of the muscarinic. A drug called phosphostigmine takes care of the nicotinic, which is the muscle problems. So you start to reverse the issue with this guy. And then you save him from a hemodynamic standpoint, but the guy's like this. He's got no motor strength whatsoever. This is where phosphostigmine works. There's a couple of articles coming out in the tox literature in the past 6 months that are castigating this, but the number of patients involved, is extremely low. But it's going to be interesting to see where this goes because, frankly, it's pretty hard to find phosphostigmine. It's a drug that hospitals don't use every day for everything. So that's anticholinergic syndrome, and that's going to be in your older patient population. But you can see the lookalikes. Guy looks septic. He's red. He's got urinary retention. He can't pee. He's got prostatitis. He's disoriented. He's all over the place. That looks like your average psych patient or your average patient in a nursing home who's septic. Now you got a little different thing. You're going, maybe he's anticholinergic. Maybe that drug that is not so benign that we give these guys. Benadryl being one of the top at the top of the list. We want you to sleep at night. Take Benadryl. Maybe even a little Haldol would help you at the same time. So be aware of anticholinergic syndrome. All right. Well, let us go down on my other list of things. I'm going to tell you what are very dangerous drugs that you will go, you got to be kidding. The most toxic drug in your home is Old English furniture polish. We talk about viscosity of liquid agents and their ability to be absorbed. Old English furniture polish is a hydrocarbon. Hydrocarbons are very dangerous from the standpoint they affect two entities, your ability to breathe and your ability to think. People that get into this class of drugs don't do well. This is not very good. They'll come in and they've got empyema, they've got abscesses in their chest. You go, what did you get into? Well, I drank Old English furniture polish. How it got into the tox literature, because most people are like, I don't even know what the hell that is. Going to the tox literature and say, this is a drug which has surface tension, which is different than its viscosity. You pour it on a table and out it goes, just all over the place. And you come back 5 minutes later and it's completely dry. Well, that's what it does in the lungs. I had fun with this last night trying to remember some of the other ones that are interesting. You go to pick somebody up and they wanted to mow the yard today, but the best thing to do, I didn't want to go get gas, so maybe I'll suck it out of my car. That'd be a good idea. You know, what the heck. He siphons it and you get a call 12 hours later, guy's coughing, maybe even a little hematemesis or hemoptysis, short of breath and not himself. You don't see this with diesel fuel, interesting enough, but you see it with gas products where they don't even know they aspirated it. They got a little bit down there, and now this guy has developed pneumatoseals in his lungs. He looks really bad. So siphoning gas, as entertaining as it sounds, is not a very good idea. But when you see this guy and you're going, there's his lawnmower, there's a hose, there he is, by any chance were you siphoning? And much like I tell my residents when I'm talking about tox issues, your narrative should say smells of. One of the things I forgot to put on this list was the word intoxication, whether it's gas or booze or whatever. You want your medical record to always reflect the concept of smells of, as opposed to saying on his breath. Some of these cases end up in litigation. They're going, so his breath smelled like alcohol? And you go, no, he just smelled like alcohol. And then the attorneys go, where? And you go, I don't know, just smelled of alcohol or whatever agent you want. Especially with your hydrocarbons, that's going to be one. Toluene. Toluene is used for a number of things in the pain industry. Also, lighter fluid, same thing that we talked about with the other agents with surface viscosity, etc. These drugs or these agents in very minuscule amounts can cause tremendous problems in the pulmonary tree. So the guy that's got the Weber grill out there who wants to heat up the house tonight, and oh, by the way, I squirted xylene or toluene on here, and man, I just can't catch my breath. I'm just not doing well. These people can develop what clinically looks like flash pulmonary edema. All right. Okay, let's talk about specific agents that we don't think a whole lot about. Let's talk about Tylenol. Chart review, we pick up a guy, he's yellow. His liver functions are elevated, he ain't right, and he's going to go to a liver center. And somebody said, did you get a Tylenol level? And yes, we did. When he came in, we got a Tylenol level. Did you get a 4-hour Tylenol level? And did you get an ALT? No. So Tylenol is purely based at the 4-hour level on the barorrheic nomogram that gives you some idea about what his level is and how sick he is. If you can't figure that out, then go back and look at the liver enzymes going, his ALT is elevated. The ALT, as far as the liver enzyme, is probably as good as a Tylenol level. Now, say a guy took Tylenol and Motrin and gabapentin and Gorillacillin, whatever. We don't know when he took it. assume when you saw the patient first, you go to pick this guy up, sending hospital said, he's yellow, we don't know when he turned yellow. There's no harm in doing it at 4 hours. You may be off by 20 hours. You may be off by 40 hours. So Tylenol can be rather indolent, and it too looks, in the first 4 hours, asymptomatic. You get these huge levels, and you go, that guy looks great, he can go home. Wrong answer. 12 to 24 is when they become almost what you would call encephalopathic. Altered mental status, liver functions go up, they become coagulopathic. And I think everybody is familiar with Mucomyst or N-acetyl L-cysteine, which is the reversal agent. If you have been around long enough, you'll go, ooh, is that stuff smells like rotten eggs? Exactly, that's what Mucomyst smells like. It specifically competes for NADPQ as a liver enzyme. And now we have a new armamentarium for liver dysfunction with Tylenol, and that is liver dialysis. It's very expensive. It's literally a machine, and we dialyze directly from the portal vein and go strictly to the liver to get rid of the Tylenol substrate in there. But again, if Mucomyst is IV and Mucomyst is also oral. In the oral form, we used to try to hide it by putting it on ice cream, and everybody says this ice cream is sour because it does smell very bad. So if you've got a true Tylenol toxicity, and you've got liver dysfunction, whether encephalopathic, platelet count's down, total bili's up, ALT is up, they probably need to go to a place that can do liver dialysis, which is mostly places that do liver transplants. All right, aspirin. We talked about it earlier because it's one of those things when I've got residents and they present a case, yeah, guy's got the flu, and you're going, what does he take for a fever? I don't know, I guess aspirin, and he takes some over-the-counter stuff. BC pills. Yeah, BC powder, that's a good one. Did you get an aspirin level? No, I didn't. But his gap is 24, and he's altered, and he's got a fever. So are we going to do a spinal tap looking for meningitis, or are we going to go back and track through that and go, assume that 140 milligrams per kilo or 14 grams of aspirin is a toxic dose? Any level greater than 30, they're going to get in trouble. Any level greater than 60, they got to be dialyzed or they die. Aspirin is in multiple agents. Most people don't know Pepto-Bismol has a salicylate base in it. The one that's most common is BC powder because it's got caffeine. And in the day, truck drivers used to like it because of caffeine. It could keep them driving for a period of time, but it also had a huge salicylate dose level in it. So aspirin is one of those lingering off on the sidelines that if you don't ask the question, you're going to go down the wrong path. All right. How many people pick up drugs and they go, I'll pick this guy up, psych facilities on citalopram. And he's acting funny too. He's febrile. His EKG, he's got sinus tach and his complexes are somewhat widened. But his pressure's okay and everything. And you pull up your med list and you see citalopram on there, which is a very common SSRI. For the people who are listening to this who have a couple of gray hairs like I do, we remember the days of Elavil toxicity. Those class of drugs were incredibly cardiotoxic. So the SSRIs came out, and the drug reps were all over the place saying, don't worry about cardiotoxicity with SSRIs. It doesn't do it like the tricyclic antidepressants did. There are still tricyclic antidepressants, and the number one use for that is enuresis or bedwetting. There are still primary care docs who give mom, just give him 12.5 of Elavil before he goes to bed tonight. It will cure enuresis and get rid of his bedwetting. Also, people use it as an extremely inexpensive conduit to go to bed at night. Take some Elavil, even though they think Elavil isn't, and they're going the wrong direction. So the SSRIs came out, and we were promised that that's all gone. No more cardiotoxicity with SSRIs. And then citalopram kind of ran to the finish line and said, how about us? And we now know that SSRIs can cause the same pathology as Elavil and that class of drugs. If you are dealing with a tricyclic antidepressant, and we're talking a lot about when is bicarb used, this is one use for bicarb is TCAs. Interesting people, they'll present a triage, and they'll be talking to you, and then the nurse will go, hello, and you notice this guy's widening out his complexes, and you go, oh shit, and he's bradycardic as he can be. they can get really, really nasty, the tricyclic antidepressants. But this is one time when bicarb actually works. Don't see much of it out there, but if you're scratching your head going, this doesn't make sense. So the rule of thumb back then, if you had a TCA that came into triage, they didn't get put in the back of the triage booth. We'll get all the gonorrheas out of here, and then you come back. This is our guys, follow me. And you put them on the monitor, and they will go down on you in nothing flat. Very interesting drugs. Let us see. Phosgene gas. Everybody smells phosgene gas. This is one that they say it smells like wet hay. It's also known as sewer gas. Areas where there may have been housing districts put up and they didn't finish the job, and they developed sewer gas in there, which is actually phosgene gas. It smells like wet hay, and it is very, very toxic. We think it responds to hyperbaric, but we're not really sure. But it has a very distinct odor to it. It's used primarily in today's world to make those things that we get bottled water in, plastics. Phosgene is one of the substrates for it, so that's where you would get that. Mushrooms. Amanita is the one that we always worry about. We don't see a whole lot of it, to be honest with you, in this part of the country, but there are areas that have huge areas in the Colorado area. We look at tox data banks. For some reason, there's an area up in there, maybe just because it's Colorado, or Amanita is very popular. This is a very toxic drug to the liver. You have to recognize it right away. The first symptom is usually vomiting and diarrhea, altered mental status, normal enzymes up front, and then within 4 to 6 hours, they denormalize. The treatment for these is NAC, but also there is a couple of very interesting literature searches right now that are revealing methylene blue works. We used to use methylene blue for a lot of other different things in radiology, but it looks like methylene blue combined with NAC and or possible liver dialysis may be the way to get you out of the trouble with mushrooms. It is the number 2 reason for liver transplantation in the United States. Number 1, Tylenol. Number 2, Amanita. What else can we talk about?
Not to interrupt you, sir, but for that specific mushroom, is that generally ingested?
Yes. Usually people, the party line is cook it and it goes away. Doesn't harm you. Wrong answer. We can't go anywhere without talking about calcium channel blockers and beta blockers. And again, the literature has something every month with these, and we all deal with it, whether it's iatrogenic or a legitimate overdose or someone just doesn't know. And they lump them together because it's easier to remember how to treat them because they're treated the same way. The problem with calcium channel blockers, specifically more so because it's a negative ionotrope and a negative chronotrope, where whatever beta blocker you may be on, we don't know, are you going for eye drops that have beta blockers? Are you going for hypertension? Are you going for whatever issue? This is a class of drugs where it is very much so something that people just cringe when they talk about, and that is charcoal. Charcoal absorbs anything that's non-ionic. So for calcium channel blockers and beta blockers that we're not quite there, that they're sicker than you know what, charcoal absorbs these drugs rather rapidly, especially if they're taking one that forms bezoars in the gut. In other words, there's a huge, 25 metoprolol pills in their gut. We know that charcoal works. Are we going to use charcoal in the field? No. I usually assign the administration of charcoal to an intern. If you get it on you or your lab coat or on the wall, it's there for eternity. But that's the rationale behind charcoal with these people, is it does absorb it and converts it. So we've got a couple of new things that some things are working, some things are not working. What is the issue with glucagon with these drugs? So glucagon with beta blockers and calcium channel blockers, if you just Google that and say, does glucagon works? The answer is could be, but there's better options. And again, the problem is intractable vomiting with glucagon. So we went to intralipid therapy, and it was used for a while as an exchange for that. You literally, the intralipid therapy is given IV, and it would exchange for those two agents. Kind of had equivocal results with that. And so, lo and behold, what do we find? Insulin and glucose work for calcium channel blockers and beta blockers. It's kind of scary when you look at the dose because it's around 1.5 per kilo of insulin, and then either a D10 or a D20 drip, whatever you want, because obviously they become quite insulinemic with those. So it's high dose insulin and moderate dose glucose that's used in these people. Very, very important, but it works, and it works very well. We're not sure if these two agents are very dialyzable, as we talked about from the very beginning. What's their protein binding nature, and can you dialyze them off? And the answer is no. So the year is 2025. So the answer to every question, including are the Cowboys going to win this year, is ECMO. ECMO is finding its source. If you've been around for a while, ECMO was a pediatric modality for many, many, many years. And it was strictly done in the peds hospitals. People talked a little bit about it. And now it's come to the surface for any number of things you guys are obviously familiar with. We don't have a whole lot of data points like we do in toxicology, period, where somebody's looking at calcium channel blockers and beta blockers and ECMO. We think it works, but we don't have a huge number for it. These are also agents that you got to be careful when it comes to the use of bicarb. Bicarb does change the pH because you're looking at the pKa of the drug versus the pH of the blood itself. And you want to get those two, like we do with aspirin, fairly close together. We think bicarb works, and as in a bicarb drip, but you may not be looking for that wide complex because these people usually are blocked down completely. So empirically, you're going to start them in a bicarb drip. All right, I put down here just some interesting ones that people don't think about. Everybody know what Tessalon pearls are? Tessalon pearls are used to stop a cough. When Junior gets into them, they stop Junior. Tessalon pearls in the pediatric population ranks right up there with a very skew in the wall reason why these kids die. Grandma's got these little pearls that you swallow them and it gets rid of the cough, and it was touted as very benign, prescription required, but the toxic centers are showing that Tessalon ranks right up there in kids as very, very, very bad. Second one, kids that eat grandma's cigarette. Not a good idea. Cigarette ingestion, literally cigarette ingestion in kids can kill them as well. Everybody know what Digibind is. So Digibind, the reason this is important to understand this is it was a class of drug for a specific drug, digoxin, which bound to it and made it inactive, and toxicity would go away. When it first came out, the manufacturer said, we're going to do this for every drug. We're going to have tricyclics, we're going to have everything, or we're going to have this moiety that goes in there that latches onto the drug, binds it, and makes it irrelevant, so to speak. Interesting enough, Digibind was the very last one and the very first one that came out. So if you're looking in the literature saying, why don't we do the same technology? It's like a lot of things in tox, it's not money lucrative, so it's been abandoned. So Digibind was one that hung out there for a while. So if you get somebody and they said, well, I had toxicity one time, which is a very dangerous toxicity anyway, Digibind may have been there. Okay, ricin, we talked about that coming from brake fluid. Castor beans, the number one area in the world that exports this is Iran. They make most of the brake fluid that we're familiar with. These guys develop pulmonary edema, and usually within 3 to 5 days, they're dead. Then there was one, I was sitting there last night putting this together. I trained in Jacksonville, Florida, big city, had a lot of huge ships that sat there on the St. Johns River, and went to medical school here, so I wasn't sure what this thing was called metal fume fever. And some of the older residents would say, guys go down inside the chimney flumes and they solder. And one of the agents, the byproduct, the ethylene byproduct of it is a poison. And they look exactly like the flu. And the treatment is put them on oxygen, come back and pick them up Monday. So we would see metal fume fever, which looked like the flu. And then somebody would ask the question, by the way, do you work on the docks? Yeah. Do you solder down there? Yes, I do. So we thought originally it was just in that industry, but it's actually guys working out in the garage and they're soldering, and all of a sudden they go, I don't feel very good. And they look sick. These guys are diaphoretic and they look sick. It's metal fume fever, which is ethylene oxide. So I threw that in just because I owe Florida something. I was trying to think if there was anything else that has some application to us. from what we do for a living. I think knowledge about this stuff is really important. But when we pick people up at sending facilities and you got the yellow guy, you're going to go, wow, did anybody check a Tylenol level on him? Organophosphates are my favorite because you can still find people spraying outside, and we go and pick them up, and the next thing we have now 3 patients instead of 1 patient, and you're going to they're giving drugs for sedation, and then all of a sudden you're mad as a hatter, you're dry as a bone, your bladder's full, and everybody thinks, what could this possibly be? And you look at the medication list, and you're going, I bet it's one of these agents right here. Ta-da!
Yeah, that just about covered the full spectrum, I feel. Plus some. So we pretty much hit all those the primary toxidromes. I feel like under those anticholinergic, there's a bunch of I guess smaller categories that I was also talking about, like serotonin toxicity. So I feel like all the same drugs that go into that are pretty much under anticholinergic.
So serotonin syndrome looks like malignant neuroleptic syndrome. We do intubate people, and we use some bizarre drugs. You use succinylcholine to intubate somebody, and within 5 minutes or so, nurse's core temp's 106. And you look down at the urine bag, and you're going, he's peeing ketchup. What is this? And that there are many agents that can cause serotonin syndrome or malignant neuroleptic syndrome. Incredibly high core temps, they have to be cooled down very, very, very quickly. Whether you do it like we do now, put them in a body bag, fill it with ice. There are some agents that anesthesia uses that they say, maybe they work, maybe they don't. But if you use any agents for paralysis, and it's primarily not succinylcholine, interestingly enough, and all of a sudden core temps go up and they start looking very, very, very bad, always think of serotonin syndrome. It also is seen in abrupt cessation of antipsychotic drugs. I took my whatever, and I quit 4 days ago, and now I'm back here in a green gown, and they think I'm crazy, and my core temp's 106, and I'm peeing what looks like, rose wine. Always think of that syndrome. That's a good one I'd forgotten.
Do you know off the top of your head any specific or common prescribed drugs out there that might go into serotonin toxicity? Because I know you mentioned
antipsychotics ranked up there.
Antipsychotics.
People looked at primarily Haldol, when Haldol is used by everybody under the sun. Now we know it also applies to benzodiazepines. 2.5 of Valium for sleep, and then the list expanded. I think the only thing it never caught on to was antibiotics, but everything else was either abrupt cessation or your dose changed from 20 milligrams to 10 milligrams, and the next day you develop this. And their CKs go into the thousands. Some of them have to be dialyzed rather urgently. Their core temp has to come down. Probably at some point we'll talk about ECMO with those as well.
Okay. Outstanding. And I know you mentioned those nerve gas agents, right? So, and I understand that generally throughout Texas, we also may have availability to like standard DOD drug kits, the 2-PAM chloride.
Yeah.
Are those generally carried within the hospital systems, or does that has to go to the government?
No, we actually, and I'm trying to remember where in Texas, and I can't remember what the disaster was, that the Army has a repository of it. It may have been for doxycycline for something years and years ago. I didn't know that we had a repository that all these drugs, the hospital didn't want to buy them, and all you had to do was access them. It was somewhere out in West Texas that you could go and get these agents, and Proto-PAM or 2-PAM was one of those agents. Because the hospital does look at the shelf life and go, we used it once last year, and it was $7,000, so why are we going to order it? Right. So those are drugs you can go through and actually, and it was an antibiotic that we had for something, and I don't remember what it was. It was way before the pandemic, where people were really scared to death of it. So the military's got that.
Okay.
All right, hold on.
Do you think that topic was worth catching in this, our little discussion about the opioid?
Sure. I mean, okay, quickly. Yeah. You need to appreciate the fact that opioids withdrawal is far worse than narcotics. Narcotics are what they are. There's another agent that we actually use for narcotics, and it's catapress or clonidine. Antihypertensive, out there for years. But it looks and acts just like an opioid. So if grandma's on point to a catapress and she doubled her dose and she is looking apneic and the usual Down syndrome type, they're not Down syndrome, but looks down, you give them Narcan. Everybody goes, Narcan for catapress. It causes confusional state in older people, causes antihistamine, but you may be a hero and then go, and I gave that guy Narcan, and he woke up from his catapress overdose. And catapress does come as a topical too, as an agent. So, with your benzos, these people require large doses of benzodiazepines to reverse them. There's a drug called Reversed. If you guys will remember, that came out and flopped very quickly, and that was a drug that reversed benzodiazepines. And it came into EMS rule or literature when they said, we give you too much of a benzo, now you're apneic, we're going to give you a drug called Reversed. It's a good drug if you want to witness a seizure, because that's what happens when you give Reversed. So I don't even know if it's made anymore, but that was going to be part of the coma cocktail, D50, Narcan, Reversed, and then people, and the reason it was called Reversed because of the benzo Versed, and then it lost favor because these people seized big time.
I believe it is still made. I've seen it fielded or attempted to be fielded in other agencies.
I've seen it all the time. We thought it was the godsend. Oh, this is great.
As soon as we found it at the other place I had worked, we pretty much sidelined it immediately. Yeah. Just understanding, like, all right, we're just going to do seizures if this is utilized. I think that hits most of our topics. Brian, can you think of anything else worth hitting on?
Brian, let me talk about one more thing that I don't know how well we do at pre-hospital as we do, and that's COA scoring, CIWI.
Yes.
You can get all this crap off of MD count, but it's kind of like the Glasgow Coma Scale. A neurosurgeon may get a scale of 8, and you get one of 12, and there's this disparity. Same thing with the COA. Do you have palpitations? Do you have tremulous? Are you sweating? Are you having auditory hallucinations? It's a nice tool if we're doing an alcohol withdrawal state, which can be really, really, really bad. Because remember, they're ophthalmoplegic, they're febrile, and they're ataxic. That separates alcohol withdrawal from DTs. The COA score it means a lot. And currently we're looking at the use of phenobarbital for these people. As opposed to the conventional stuff, which was multiple agents. We're starting to look at, for alcohol withdrawal, by itself, phenobarbital may be the drug of choice. An ongoing study right now is, when all else fails, go to ketamine. So we're looking at that. But the COA score is a nice way. Say you're transferring the patient over and you go, hey, this guy had a COA score at hospital 8 of 9, and we're getting a score of 3. That's better than saying, well, I don't know, he was a jerk in the aircraft or something like that. It's just like into the scoring systems, there's continuity for it. So we want to make sure everybody knows what the COA score is. So when you're following the patient, you got a 45-minute flight, the guy's alcohol withdrawal, and he started out with a COA greater than 8, which should respond to benzodiazepines, and now he's at 12, you're losing ground. And that means something to the accepting facility because they're going, oh, we just heard that he was, he had some tremulous, something like that. So COA is probably something we probably ought to think about on these long transfers, or we'll call it out for some guy is alcohol withdrawal is one of the worst things you can witness. These people go down big time. I'm really interested in where we're going to go with the phenobarbital, though. I mean, there's always access to the Poison Control Center. In our immediate catchment area here in Dallas-Fort Worth, the Poison Control Center is in Dallas, and they actually have available a toxicologist to talk to you. So you can call in and they can look on the microfiche or whatever and say, oh, it's an ACE inhibitor, this is what we would do. But if you ask for a tox consult, you can get it. I think there's people for some reason don't want to call the Poison Control Center. I think they're going to think I'm an idiot. I see a lot of patients and I see a lot of different drugs, but I've not seen them all. So if I get above my head, I'm going, hey, let me get a tox consult. Let me talk to one of the tox guys. So that's the nice thing. Galveston has another one, which is quite popular, been around for a long time. But the one here is attached to the UT Southwestern Toxicology Division. So you can actually get a doc. If you say, I really want to talk to the doc, and they'll say, are you sure? You go, yeah, I really want to talk to one. They'll usually get somebody online to walk you through it.
Perfect.
We good?
Great. Yeah.
Miller time.
Yeah. Thank you for watching this toxicology lecture for February. Again, thank you, Dr. Simonson.
Sure.
It's been a great lecture. And Herb Corley and Whitney, thank y'all.